And now I'd like to introduce today's speaker, Dr. Juliessa Pavon. She is an associate professor of medicine, biostatistics, and bioinformatics, and head and neck surgery and communication sciences at Duke University. As a hospital-based geriatrician and clinical investigator in the Division of Geriatrics and Palliative Care, she also serves as the Associate Director of Clinical Innovation at the Durham VA Geriatric Research, Education, and Clinical Center. Dr. Pavon leads a research program focused on medication deprescribing and functional outcomes in older adults, integrating informatics, artificial intelligence, and wearable technology to advance her work. She is also the Associate Scientific Director of Informatics and AI at the Duke Aging Center and leads data science initiatives at the Pepper Center. Dr. Pavon is also a co-investigator with the U.S. Deprescribing Research Network's Data Harmonization Core, serves on the National EPIC Geriatric Steering Board and the Society of Hospital Medicine Research Committee. And she is a former Tideswell Emerging Leaders in Aging Scholar. And with that, I will turn it over to Dr. Pavon.
Great. Thank you so much, really. I'm thrilled to be here and appreciate that kind introduction. And I've really learned so much. I've always learned so much from these webinars. And I'm really grateful for the opportunity to be able to share something exciting with you as well today. And certainly, I want to acknowledge that I've benefited a lot from USDEN throughout the years, first being a part of the cohort of the Junior Investigators Intensive Program, and also being part of the Data Harmonization Core led by Drs. Sasha Dublin and Liz Bayless. And I've had all of those experiences really early on, have contributed to the project that I'll be presenting today, and wanted to really thank you again for this opportunity to be here. So first, I'd like to just start off with some disclosures. So one is that I have no financial disclosures or conflicts of interest. This work is funded by the National Institutes of Health as an NIA R01 award. And more of a disclaimer rather than a disclosure is that I love data science, but I am not a data scientist in the true sense of the word. So I'm not the one necessarily conducting the data programming or the data analytics. But I am considered to be an applied data scientist or a clinical data scientist in the sense that I do help to merge and connect clinical problems with data science methods. And two areas where I've really focused a lot of that work has been in the area of function and functional decline, as well as deprescribing, which we'll be talking about a little bit more about today. So as mentioned, I am a hospital-based geriatrician and as well as a clinical investigator. And my main areas of focus have been around improving hospital care of older adults, specifically around high-risk medication use, as well as function and mobility, and as well as hearing loss. And have really started to apply those just more generally across aging populations overall. And a lot of that work has leveraged the use of informatics, wearables, and artificial intelligence. And the project that I'll be presenting on today really highlights some of that work around informatics and AI. So going back to where we're going to focus on today, I'll be presenting a blueprint of a project that we're about to launch. And this is really coming at a very exciting time, really, as we stand at the intersection of both the immense potential of AI, but as well as the critical challenges related to AI. And my approach to AI all along has really been to see AI as a tool. It's a tool, it's a method to help solve a problem, but it's not really a standalone solution. So the success to me in AI really hinges on focusing on the clinical problem first, and then using AI as part of that broader solution. And so I want to start off by introducing kind of a real clinical pain point that I've often encountered in practice. And it's that type of pain point then that I feel drives the need for innovation and where I believe that AI tools can really be helpful. So let's talk about a growing problem, which is that nearly 4 million older adults are taking 3 or more central nervous system medications, things like antidepressants, antipsychotics. And when a patient and provider sit down and decide to reduce or to stop these medications, which medication do they start to prioritize? And when you consider all the individual factors, the patient preferences, that adds a lot of complexity to that decision-making process. And it's that uncertainty then that becomes a clinical pain point for many providers. And so here, for example, you have Mrs. P. She's on several CNS acting medications. And together with her provider, she wants to reduce her medication burden. She wants to help lower her risk of falls, reduce her side effects, improve her quality of life. But where do you begin? Well, here then enters AI. So now imagine a world where you have an AI data tool, essentially a data-driven tool that can analyze the medical history, the documented symptoms, the drug interactions, and offer more of a data-driven recommendation for deprescribing. And so here I want to emphasize that AI is really not meant to be the primary solution, but it's really meant to be a partner in the decision-making process to help achieve the same goals that Mrs. P has. And we know that deprescribing, certainly as many of you know here, is defined as a systematic approach to stopping or reducing medications aimed at managing polypharmacy and improving patient outcomes. And it also comes associated both with benefits as well as harms. And because of those benefits and harms, it can become clinically challenging for providers. It can become even emotionally challenging for patients. And so what we need potentially is a better understanding of what these risks and benefits are to then provide more certainty in the decision-making process for providers. And so early on, our research team conducted some qualitative interviews for hospitalized older adults, as well as hospital providers. And what we heard the clinicians say is that they have a very strong desire for better data-driven deprescribing tools, tools that can be embedded in the EHR, that can provide some more of this automated clinical decision support. And they want that in order to be able to really help navigate that complexity in the decision-making process. And we do have tools available today, like the American Geriatrics Beers criteria, the anticholinergic burden scale and calculators, as well as the stop and start criteria. But the challenge is that really most of these tools adopt kind of this one-size-fits-all approach. They really lack an ability to kind of tailor the recommendations to individual patient needs. And so the question here is, can AI make a difference? Can these data-driven AI tools offer us a potential to move beyond the universal criteria of deprescribing and supporting more individualized decision-making? And to me, why that matters is because even though deprescribing certainly has been shown to be promising, its impact on clinical outcomes still remains somewhat unclear. And we saw that in some early work that we did as well, where we looked at a cohort of older adults who were chronic benzo users. And we assessed the association between medication discontinuation, so benzo discontinuation, and clinical outcomes. And one of those clinical outcomes was falls. And what we found was that there was no association between medication discontinuation, so benzo discontinuation, and falls outcomes, either using a 180-day gap of deprescribing as a definition or a 90-day gap definition in deprescribing. And we also found that when we looked at a outcome of cognitive impairment, where we found that over 6 years, discontinuation was not associated with incident dementia. And certainly we can't read too much into this, right? This is a single site study. It's one medication class. It's a relatively small sample. But what it does start to lead us to question is it possible that we might not be necessarily matching the right medication to deprescribe to the right patient? Could there be something where with this one-size-fits-all approach, we're missing people that might actually benefit from deprescribing? And so we started to look at that with some preliminary work as well, where here we wanted to identify patients that potentially could benefit from medication discontinuation, and benefit here defined as having a falls reduction. And so as an initial step, we used a logistic regression model to first predict falls. And the model predicted falls with an accuracy of about, with an AUC of 0.78. But what we found was that medication discontinuation was not one of the factors that predicted falls. So then we trained and tested a machine learning model to predict falls. It did improve the accuracy of our falls prediction, but again, medication discontinuation was not one of the factors that was predictive of falls. And so then what we did was we identified a subgroup of patients who actually tended to be perhaps at higher risk for falls. we retrained and tested a machine learning model within that subgroup. And there we did find that discontinuation of benzodiazepines in this specific example was associated with false prediction, especially in patients that were younger, had fewer chronic conditions, and had comorbidities of diabetes. And certainly what this, again, just starts to help us to see, or the potential that we have here, is that we can apply methods like machine learning to potentially uncover hidden patterns in otherwise very complex data, and be able to start to potentially match and look to see for ways where we can match deprescribing to clinical characteristics of individual patients. And that is what we're trying to build here with these AI-driven tools. We're trying to build a tool that can tailor deprescribing recommendations based on individual patient factors, such as the ones that are listed here, and that we can extract from data like EHR data. And so the opportunity here is that we can build towards something that's called an individualized treatment rule, which helps to match patient characteristics to the treatment choices that optimize, that give them the best chance for a successful outcome for each patient. So what are these individualized treatment rules? These are basically data-driven, individualized recommendations. These are based on models that recommend optimal treatments, in the sense optimal because it achieves the best outcome based on a patient's unique characteristics. So it's like a personalized guide for a clinician, for instance, trying to make the best treatment decisions for each individual. And why does that matter? Well, it matters because we know every patient is different, right? Every patient they're different with their age, their health history, other factors that can influence their treatment response. And what we have here on the top right, in current practice, treatments are typically applied broadly across groups, leading some patients to benefit, some patients to have no improvement, and other patients to even experience some harm. But with these individualized treatment rules, what you have now is that you can tailor decisions based on a patient's unique profile. And so now you have essentially patients that can benefit, more patients that can benefit really based on these unique profiles, and you're improving outcomes essentially now for more patients because it's tailored to the medication treatment that's going to give them the best outcome. Here's another illustration of that. So certainly in traditional approaches, what we have is a focus on average treatment effects across a population. But with the individualized treatment rules, what you have now is that you can identify patients who can benefit most or who can benefit least based on their individual characteristics. So for example, in patient A, a treatment might actually lead to worse outcomes than average. But for patient B, the same treatment can actually result in better than average outcomes. So with these individualized treatment rules, if you tailor the treatments for patients A and B, you're hopefully maximizing the benefit actually for each of them. And so this is moving us away from kind of this one-size-fits-all approach to more of a precision medicine approach, with the goal really of being able to improve outcomes beyond the averages by, again, ensuring that patients receive the treatments that are best suited to them. And these individualized treatment rules have had proven success in other areas of medicine, as listed here. And as a new frontier, we're hoping to bring these individualized treatment rule concepts to the deprescribing landscape. So how do we go about building these individualized treatment rules? Well, certainly they do leverage advanced AI methods. And these methods are intended to help analyze patient data, identify patterns in the data, and then be able to predict the best treatment decisions. And in this case, the treatment that we're referring to is deprescribing. So actually applying deprescribing for each patient. And the process of building these individualized treatment rules do involve a series of steps that I've listed here. And we'll be going over these steps in the subsequent slides going forward. So the first step is identifying a data source. So the data source that we'll be using for this study is a multi-site EHR data set using the common data model from PCORnet. And we'll be using data across 3 sites. So Duke, Vanderbilt and the Medical University of South Carolina. This is going to give us an estimated cohort size of over 270,000 patients. And then we're going to link that EHR data to their Medicare claims data through this new program through the NIA called the NIA Data Linkage Program. And the reason why we want to link to CMS claims data is to be able to give us the medication dispensing data so that we can have more accuracy around defining medication discontinuation. Because a lot of these common data models have medication orders, but not necessarily medication dispensing. And we've learned from some of our work through USDEN and the Data Harmonization Core that really leveraging dispensing data can be very valuable in this type of deprescribing work. The medication classes that we'll be focused on for this project are the 8 medication CNS classes listed here. We'll also be looking at 4 outcomes, 3 outcomes related to benefits, so a reduction in falls, cognitive disorders or hospitalization, and 1 outcome of deprescribing harm as well, which is having adverse drug withdrawal events. And we're going to look at those outcomes over a 2-year period. Then the next step that we need to address is this issue of bias in observational data. And the reason for that is because historically, these individualized treatment rules have actually been developed using randomized controlled trials. The benefit of randomized controlled trials is certainly you have clear treatment assignments which create balanced groups that allow you to compare the average treatment effect between the groups. But with observational data, you have unbalanced groups potentially due to the lack of randomization, and therefore we have to address things like unmeasured confounders in the data, which can influence our outcomes. And so to do that, we're going to apply propensity scores to be able to estimate the probability of having the treatment. So in this case, it's the probability of having a medication continued or a medication discontinued. And to do that, we'll apply causal inference methods using, for instance, inverse probability weighting to be able to create balance between the groups to approximate a randomized controlled trial as much as possible. The other issue that we need to address here is this problem of the counterfactual. So remember here that our task is to develop individualized treatment rules and to look for individualized treatment effects. What I showed you before is the ability to look at average treatment effects between groups, but with individualized treatment rules, you're only looking at the individual. And so within an individual, you can only observe one scenario. You can only observe if the patient receives the medication or if the patient does not receive the medication. But you can't observe both things in one person. So the unobserved scenario becomes then the counterfactual, and that's unknown to us. And so to be able to calculate these individualized treatment effects, we actually have to estimate both scenarios for that one person. So for example, here we can observe that a patient takes a sleeping medication, but they might actually sleep well. The counterfactual would be, well, what if that same patient had not taken the sleeping medication? Would they have struggled to sleep? We don't know. And so in order to be able to handle that situation, the solution again here is the use of causal inference techniques, which allow us to predict the counterfactual outcome. And by being able to predict that, this enables us now to be able to estimate the difference in the outcomes for an individual under both scenarios, under taking a medication, for instance, or not taking a medication. So now, once we've estimated that probability of taking a medication or not, so again, in this sense, medication discontinuation or medication continuation, now that we've gone through that step of using causal inference methods, now the next step it becomes being able to predict the outcomes that we're interested in. And for that, we're also going to leverage AI machine learning methods that are going to use EHR data, looking at patient characteristics to be able to learn and train and test a model that can learn to accurately predict these outcomes. And I've illustrated this here with this example from breast cancer. where it's taking a patient's electronic health record, their individualized patient characteristics, training and testing a machine learning model to then be able to predict an outcome. And what we're going to do next is take a deeper dive into how the machine learning is actually learning, going through that process a little bit more. So what's happening in that box? So to learn, typically, the way the machine learning and AI at a very high level works is that it's detecting patterns in data to then be able to learn from the associations of those patterns with the outcome. And so in this example here, AI can detect patterns in EHR data, such as patterns in lab values, BMI, other vital signs, to be able to predict the outcome. And in this case, the outcome was a progression to diabetic kidney disease. But in our study here, the outcome is going to be being able to predict things like falls outcomes, cognitive impairment, hospitalizations, adverse drug withdrawal events. So that's at a high level. It's looking for patterns in the data. Well, how does it do that? So the process for that also involves a series of steps. So the first step we've talked about, which is this need to be able to predict or estimate the probability of receiving the treatment through these causal inference methods that involve, again, both the propensity scoring as well as predicting the counterfactuals. Next, we need to be able to predict, again, the outcome. And to do that, we're going to apply several machine learning algorithms. Algorithms are actually the mathematical computation. And some of those algorithms are, for instance, a random forest algorithm. So the way the random forest algorithm learns to be able to predict outcomes is that a random forest is made out of individual decision trees, as illustrated here. Each decision tree is going to make a prediction. And then as a random forest, it learns by taking the majority of those prediction results and coming up with a final result. So that is the example, for instance, if I gave everybody a clinical scenario of sepsis, gave you kind of some of those features, high elevated temperature, having a elevated white count, having a tachycardia. And if I gave all those features to everybody, and then I asked you to vote whether you think this patient has sepsis or not, I would take the majority of everybody's votes, and that would be what I would classify as the best prediction for that patient. So that's an example, high level, of how random forest is learning to make these predictions. Another algorithm that we're going to use is a gradient boosting machine learning algorithm. And the way those algorithms work is that they're actually learning by errors. So that is, in a sense, by learning by the errors it's making, it's refining then the next decision point. And as that keeps refining those decision points, it's making less and less errors, and then comes up to the best prediction at the end. So an example of that would be like a game of hot and cold, where you make a guess, and I would say you're getting hot, you're getting cold, you're refining your next guess based on the information that you have on the prior guess. So that's how gradient boosting works. But then how this all comes together is, again, we combine both the counterfactuals and using our causal inference methods together with the machine learning methods to predict the outcome. We combine those together all into what would be called the machine learning individualized treatment rule model. And so what I've given you, in a sense, is like a view of the inner workings, the insides of an engine of how the machine learning is actually processing and working to come up with these predictions. But now I'm going to come back out at a 10,000-foot view here and put this all together by showing you that then what happens is that now for each medication class, combined together with individualized patient data, we essentially will run that data through these machine learning models, which, if they're trained and tested to work well, they will accurately predict the outcomes that we have here, the 4 outcomes listed here. And essentially we'll have basically 32 models, 1 model for each medication class and for each of the outcomes. And this process reflects very much what I showed earlier in the prior slides of, again, taking EHR data, running it through the machine learning algorithms, and then coming up with a model that can accurately predict these outcomes. Then as a next step, once you have these models, it becomes very important to understand how the model is learning, in a sense, kind of looking under the hood to see what happened. And one way to do that is to identify what are the features that are really driving those predictions. What are the individual characteristics that are driving those predictions? And we do that through a process called unsupervised machine learning. So we will apply that as a next step. And then ultimately, we bring everything together in combination by combining both our causal inference methods to be able to estimate, again, the probability of receiving or not receiving a treatment, and then combining our machine learning models that help us to predict the outcome. And so now what we have is, for each individual, we have both their counterfactuals as well as their predicted outcome, and then we can measure and calculate the individualized treatment effect, the difference between either taking a medication or not taking a medication in the outcome of either falls, hospitalization, cognitive disorder, or adverse drug withdrawal events. And then one more step to put it all together. Well, then you might ask, well, how do we do that with a patient that is taking multiple medications? Well, how that works is that, again, we're going to have one model for each medication class. And each model is going to give us a prediction of the outcome. So let's take just the prediction of falls, for instance, as an outcome. So for a patient like Mrs. P, who's taking 3 or more medications, we run the models on each of those medications, and it comes up with a prediction of having falls. But then what the individualized treatment rule does is that it ranks the medications for deprescribing that would then help you to select the medication that would help it achieve the best outcome for that patient, for that individual patient. And so what we do by doing that then, by being able to select the best medication to discontinue for each individual, is that we hope to be able to achieve outcomes that are better than the average treatment effect, better than if we had just used kind of a one-size-fits-all, non-personalized approach to deprescribing. That is the benefit that we would get from being able to apply this type of methodology to making individualized predictions. And then a crucial step for me with any model that I've developed is really taking a critical step in identifying and mitigating any biases that could potentially occur in the data set or as part of the model development lifecycle. And there's a series of ways that you can do that all across the model development process, but it's a very critical step that I'm excited to be able to explore further as well with this work. And I did want to take a moment to kind of highlight some of the innovation that I've just described in this project. And one of the key pieces of innovation here is that we would be combining multiple machine learning algorithms, such as the random forest, gradient boosting, among others, to create actually what is known as superlearner or ensemble methods, because they take an ensemble of these machine learning algorithms to actually come up with something that's essentially a super prediction. So it takes the best predictions of each of these algorithms to come up with supposedly what would be the most accurate prediction, taking them all as a combination. So that's certainly innovation that we're proposing here. And the next is the use of what is called doubly robust methods, which actually is the integration of both causal inference methodology as well as machine learning techniques to be able to also come up with more comprehensive insights and being able to handle, again, observational EHR data. And then another key piece to this has been also the what we have planned to involve clinicians early and often in the decision-making process of this model development. So the model development piece a lot of times happens, and then the end user gets engaged in the process. And sometimes that, there's missed opportunities there. So we're really excited about, again, having that early end user engagement throughout the model development process. So that was certainly a lot in terms of just creating these models and pushing us more towards this individualized deprescribing. But how do we make that actually all understandable and usable? So that's where the next aim of our study comes into play, which is that what we're trying to achieve is coming up with a usable prototype for clinicians to actually take that information of those predictions, for instance, and translating it into something that's actually actionable and that can be data-driven as well to help with that decision-making process. And the methods that we're going to use for that is something called explainable AI. And explainable AI essentially ensures that clinicians can better understand the how and the why behind some of these machine learning recommendations and these model recommendations. And so the purpose is really to be able to then enhance that transparency, the accountability of how AI is making these decisions. And it's essentially helping to explain the why things are happening behind kind of the what that we're trying to accomplish, relevant to the who, the stakeholder in a given where context, in the context. And the methods for explainable AI typically involve 4 key steps. One is around the scope of the explanation. So one way to define scope is, do you want to be able to explain things in a way that explains how the whole model behaves, or just focus, for instance, on a very specific part of the model? And for us, we feel it's important to be able to explain things as a whole, how the entire model potentially would behave. The next is around the diagnostic utility, so the applicability. So for us, we'd be using kind of what is termed as model agnostic, because we're using very well-established models that can explain, that can enable these robust explanations really across very diverse data sets. So these are models that can be used across very different types of data. And we feel it's important to be able to explain it at that level, something that can be applied to other data sets. The next is around the timing of the explanation. So our approach, because we want to make this as more real world as possible, we would focus our explanations in a term that's called post hoc. So emphasizing kind of the part of the process that's closest to implementation. And then there's explainability across either more of a human interpretable way versus a machine interpretable way. And certainly for us, we would focus more on human-friendly explanations to help guide, again, these decision-making process. So these are all methods, again, to just help uncover and be able to focus on the end user being able to understand what's happening behind these machine learning models. So as an illustration of that, I think this is certainly great to illustrate that. It's illustrating that a lot of times right now, the machine learning models and these AI algorithms give us a decision or a clinical decision point, but you're still left wondering, well, how did it get to that point? By applying things like explainable AI, you're much better able to understand the how. How did it actually make those predictions? So that's what we're hoping to achieve with that. As I mentioned, though, what we're trying to build is an actual clinical interface, a prototype of an interface that clinicians can engage with. And for that part of it, we're going to apply design thinking methodology, more of a user-centered design methodology. And so here we're going to apply the IBM design thinking playbook, which are essentially a series of exercises that goes through each of those stages of design thinking. And for that, we're going to recruit both providers as well as patients to go through these design thinking sessions. So 3 design thinking sessions that are going to go through each of those stages of design thinking. And the exercises that they'll do during those sessions are part of this IBM playbook. And here are some examples that I've shown here across the sessions on this slide. But for instance, in session 1, we're going to focus on a part of the prototype development, which is around emphasizing the problem, defining the problem. So that's more focused on understanding key challenges and deprescribing. Next, we're going to focus on things like in session 2, ideation, where you start to come up with kind of creative ideas around how to share, how to use these types of models in shared decision making. And then in session 3, ultimately, you start to test a kind of a rudimentary prototype of what the clinical interface could look like. And you start to get feedback to be able to help refine what that prototype potentially would look like, and start to evaluate what the usability is and what its potential is for application in real world deprescribing. And so the goal of this process here really is to be able to develop a much more clinician friendly interface, as well as be able to support shared decision making, and all the while addressing kind of that need for transparency in what the AI models are doing. So those would be the key goals of these sessions. Now, kind of stepping back more broadly, why that's so important, why that usability, that transparency is so important, is because it aligns with this understanding of having responsible use of these AI technologies. And certainly as these technologies advance and continue to move through the pipelines, we're going to be tasked with having to use them in a responsible way. But responsible use really can mean very different things for very different people. And that's why we want to have all these stakeholders together to be able to understand what responsible use means to each of them. So for example, for patients, responsible use might be having AI solutions that are, proven that they're effective, but that all the while also keep their information private and protected. For communities, it might be, applying the technology in a way that's fair and ethical. For more of a provider, it might be making sure that they stay trustworthy and that they stay active and involved in the patient care, that they're not in some ways overtaken by the AI. And for caregivers, in the sense of medical staff, it might be feeling like that they can actually understand, what the AI model is doing, and that requires, again, transparency, validation. And so by hoping to, apply some of those principles, bringing the principles of responsible use to the work that we're doing, we hope to be able to avoid certainly unintended consequences, but also to make sure that we're integrating all the voices early on in the process. And where all of this fits into the landscape of AI, I always like to show this just so that we kind of get a sense of certainly how fast AI is evolving, and also where this innovation is. So certainly this work involves the use of machine learning as an example. And the reason why we're starting to see, a lot of these algorithms in clinical practice right now is because things like machine learning have kind of led the pack in terms of AI, development over time. So that's why, we're seeing that more and more often right now in clinical practice. But things like generative AI, that is still at the slope of innovation. We still have not even seen yet the peak of what it's potentially going to do for us, and certainly even responsible AI that is also still on the peak of innovation, because what's going to happen is, as all of these types of AI technology come into play in clinical practice, it's going to feel even more like the wild, wild west, even if it doesn't feel like that already, but it's even certainly going to feel more like that. And really, we need to have kind of infrastructures in place to help provide some guidance and, around safe and responsible use of these types of methodology. So I say that because a lot of the work, I always try to ground, the fact that this work has the potential to influence patient care. And so this becomes a very big part of it and an important piece to it all as well. And then also more broadly, so I know that geriatrics, we always love our 5 things. Like we have our 5 M's, we have our 5 T's in research. And here I would love to be able to make the 5 A's of responsible use of AI. But in terms of what I feel every geriatrician, but really this can you can change the label to every clinician or every researcher, but 5 things that we should all know about responsible use of AI is certainly how it works. So as an example of that, being able to use, again, methods that are pretty well established. So for this project, using gradient boosting, random forest models as an example. Also being able to appraise the evidence. And by that, it's making sure that the way this project is constructed really follows guidelines around the use of AI in observational data. So just very briefly about that, there are established guidelines for reporting on AI prediction models that come from observational data, for instance, using the tripod AI guidelines. So this project does follow all of those kind of reported methodologies and guidelines. There's also things like Spirit AI, which focus more on AI clinical trials. And there's even things like Decide AI guidelines, which are meant for projects that are more about translating algorithms now into real world clinical use. And so I wanted to just highlight that. But then again, this project also focuses on things like mitigating bias, again, a very important step that we should know about, as well as assessing the training data. So once these models are developed, it's really important that they're validated both internally with the training data set, but also externally. And the opportunity to partner with PCORNet, for instance, gives me an opportunity to really engage in both internal and external validation. And then lastly, a very important step as well and towards responsible use is being able to build patient trust. And why that's important is because with any of these AI models, you kind of have a fine balance between how fully autonomous you make the AI decision-making process versus whether it can be something that's more assistive in making decisions. And certainly with something like Deprescribing, I would want it to be something that's more assistive and part of the shared decision-making process. And this is kind of the levels of assistance that certainly AI models can contribute. And I would say that most of us as providers, we're probably more comfortable with decision, AI guiding decisions kind of somewhere between a level 2 or a level 3, where certainly they can provide some decision support, but still that the clinician really is involved and still making, at the end, an informed and data-driven decision. So that's certainly important with this work as well. And then building trust, right? That is certainly not only provider trust, but patient trust. And there's certainly some key steps in that process that have been certainly well published in the literature about how to begin to use AI in the patient setting and really building trust, everything from clarifying how AI can assist with care, being able to present AI as a tool that's guided, that's not necessarily overtaking professional skills, that it's being able to both have that, acknowledging that it has both advantages as well as limitations, as well as that it can be used to help, in personalizing as well the decision-making process, being able to explain AI in very simple terms, and also being able to provide real-life examples of how AI can be helpful. So all of those, are steps, for instance, that we can take in terms of building patient trust around using AI. And one of the reasons why I like this project as well is because to me, it really flows through the data science and learning health system lifecycle, which starts out by moving data from the clinical encounter. So for instance, in this case, I am using data that's coming directly from the EHR, which gets entered through clinical encounters. It moves through kind of this data to knowledge. So analyzing the data using machine learning, for instance, algorithms as a way of analyzing the data, and then moving the data back into practice. And moving it back into practice is always the most challenging step. And that's why, that's why having the early engagement from providers and clinicians and patients is so important in this work. And certainly that's one direction that we're moving in. It's also very important that some of these projects can become scalable too, and we are working, for instance, with a team at the VA as well to look and see how we can leverage generative AI methods as well in this deprescribing process too. So hopefully more to come on that later. But again, it's very important to see how this type of work moves through kind of a data science life cycle. And then even more broadly, taking just a step more broadly, how does this all fit in the AI translational life cycle? And the AI translational life cycle, I would say, really is very close to a drug development life cycle, where it first goes through kind of a preclinical development stage, then it goes through kind of an effectiveness trial testing, all the way into more of translation or implementation into clinical workflows. This process can certainly take a very years, to go from model development all the way to bedside use. And where this type of project fits in is really more around the model development stage of the life cycle. And certainly going forward with other work that I'm also conducting is trying to find ways to help us move more efficiently through the process of model development into clinical translation. But what I hope to build even more largely in doing this type of work is certainly building a community around AI and aging, as well as being able to match these clinical ideas with resources and methodologies around AI, and helping us to really match the ideas and the resources so that we can support projects to move more from algorithm to bedside care. And again, these methods and AI in general is moving so rapidly. And at Duke, for instance, we actually use the analogy that AI tools are like frogs, where some of these are going to turn into princesses and are worth pursuing. They're worth pursuing in terms of dedicating resources and time and energy to be able to evaluate these tools. Well, there are some that are just not, that they're not going to be, worth the effort really to go through those rigorous evaluation steps. And because they're coming at us so rapidly, we have to find ways to really make that a very efficient process going forward. And I certainly hope that all of the work that I've discussed here today will hopefully eventually turn into a prince. And with that, I would like to thank certainly the team. This is very much a team effort, the mentors that I've also had along the way, and the support, again, from the US Deprescribing Research Network as well, and the collaborators that I have in this project, including Amanda Mixon, who's also part of the USDEN network too. So thank you so much for your time, and I look forward to answering any questions.
Thank you so much, Dr. Pavon, for your excellent presentation. To our attendees, please, now is the time to enter your questions into the Q&A bubble at the bottom of your screen. To get us started, we do have one attendee question already from Gabrielle. They're curious, how do you extract time-oriented information in the EHR and feed it into machine learning models? Do you use time series data, for example, or do you convert data into more snapshot scenarios for each patient?
Great. So that's a great question, and certainly part of the advancements around AI and machine learning are using some of these algorithms that can handle more of that time series data. But for us, yes, we would be using, for instance, the baseline characteristics at one point in time. So that is how it is proposed right now. And then we would use that kind of using the timestamps, for instance, of order data or of diagnostic code dates as an example. But going forward, some of the partners that we have in data science and biostatistics, they are starting to experiment with methods that can use kind of more of this time series approach. So taking into account baseline variation in these characteristics over time. And so that's actually a very exciting work, and I'm part of someone's dissertation that is working with us on this project. So great question.
Awesome. Mike, do you have a question you'd like to ask?
Oh, I have so many questions. That was a terrific, thought-provoking presentation. Just really tremendous to see the work you're doing. So one of my many questions is about sort of what's missing from the data that you use to make predictions. And there's a lot of elements to that. But one thing I'm thinking in particular in mind is for kind of historically underserved and marginalized populations, who might not have good access to healthcare, might not be getting those labs done because they don't see their doctor, or they might not be having ICD codes because they never have a chance to see that specialist where those codes are entered. And how you think about ways to enhance prediction for those underserved populations, and whether we need sort of a different way of thinking about them than lumping them in with everyone else where their unique characteristics might not be properly coded for optimal prediction for them.
Great, yes. I really enjoy that question too, because I really do feel that with any of these models that are developed, that key crucial step around bias detection and mitigation is very important. And it all starts with first understanding the data. So what I say, having data empathy. So understanding what's going into the data. So like you said, are you working with a population that might not have, yes, access to care? So already is there, yes, bias in how data is entering the data set, having awareness of that. If there is potential, bias in that process, we want to ensure that we have a very representative sample as much as possible. So for instance, using external sites, making sure that the external sites kind of have as much representation as possible around different groups. So that's key. Then it comes to handling that data. So one way to mitigate the process is, if there is concern about some of those potential biases, then is potentially downweighting or upweighting some of those variables. So for instance, if it is like labs that there's concern about patients not coming in very routinely for labs, that can actually be downweighted in the model. So there's those kind of very specific mathematical ways. And then there's the interpretation. So kind of at the interpretation level, having the awareness, right, that this can creep in to these models, and being able to kind of test to make sure that the model works the same way in one group versus another is very important. And we've learned so much. There's some great use cases in the literature about how just one variable can really, disproportionately affect, the decision process just because of the fact that it was in the model. And by taking that variable out of the model, everything became a little bit more balanced. So that's very, very important. And in terms of, thankfully, the machine learning methods do have ways to handle a lot of the data missingness as well. So, which is great. Yeah. Thank you.
Awesome. All right, we have another question from our audience related to Dr. Steinman's questions on healthcare data. Can often be problematic to work with because of how non-representative of the actual clinical situation and outcomes due to poor coding. The question is, do you already have an opinion of understanding of the sufficiency or existing data to be able to predict well?
Great. So yes, so definitely another good and related question. So early preliminary data is very important for that process to kind of understand so far the distribution of data, what's missing. I would say that understanding the data is probably what takes up a year or more of work. Really, that is where the bulk of the work really happens, and is an important part. But in terms of yes, in terms of what we feel is going to be missing, we do have a sense of that. So for instance, in medication data, because that's such a primary data point for us, we do have a sense of how much data is missing. And that's actually one of the reasons why we went from looking at medication order data, where we felt the data was not, very reliable or very good, to having to use Medicare claims data. Ideally, I would have done the whole study just using EHR data, but because of that one issue, data quality, we had to be able to bring in, for instance, another data source like CMS. So that is all part of the early work that happens. And I would say that what we have to do is be able to be aware of it and and have those steps in the model development process that can allow us to refine. So that one step, it was step like number 5, where there's an opportunity to refine the model. That becomes very important because that's where a lot of the learning happens, in terms of how good the prediction is. And if there's something that's missing, that's where we would learn about that, is in that 5th step of what I described. So that's great.
Thank you. And I think one final question we have is, what are some takeaways you could share with us on how to connect these AI methods to deprescribing use cases?
Great. So when I think about that, I think about kind of what part of the process are you trying to influence? Are you trying to use AI to identify patients that would benefit from either a clinical trial or some sort of intervention or program? That is a good space where you can use AI methods like predictive modeling, for instance, to predict and to identify patients that might benefit from an intervention. If you're more about needing to have a better way to capture data, for instance, from the medical record, and this kind of connects back to the prior question as well, whereas there's probably a lot of good information in the medical record that is unstructured, right? That just lives in notes, and that I won't be able to get to because all of these models that I just described are going to be using structured data. But to be able to capture the depth and the richness of unstructured data, I might need to use things like generative AI, large language models, to be able to get that data out of the EHR. So that would be a use case where you could combine, other types of AI methodologies. And then finally, if you're more about trying to then predict outcomes, then you might use other types of AI methodologies that are more about what we call prognostic AI, where you can predict an outcome based on whether somebody gets a treatment or an intervention or not. So that's one thing, is deciding what part of the life cycle you're trying to influence with your AI methods. And then lastly, is that a key piece of making AI useful is making sure that it's linked to something actionable. So as an example of that, the AI, the Framingham cardiovascular risk score is very good, it's very powerful, but one reason it is because it can be linked directly to, for instance, giving a statin or not. There's actually an action that's associated with a risk score like that, with the clinical decision support. So the more that we can make these AI algorithms linked to something that's actionable. In this example, the action is providing a medication or not, but in another example, it could be, linking it to, like I said, a deprescribing program or deprescribing clinical trial, then it becomes a lot more valuable. The use case becomes more valuable too.
Awesome. Thank you so much for sharing that. Thank you to all of our attendees for attending our webinar today. Our next event will be our in-person annual meeting on May 7th in Chicago, in conjunction with the American Geriatric Society's annual meeting. We have an excellent program planned and hope to see you there. Please visit our website for attendance details. The recording from today's webinar will be posted to our USDEN website soon. Please complete the after webinar survey that will be sent to you. Our webinar series will resume in June. So thank you again so much, and have a great rest of your day.